If you're a woman over 60, this could protect your health and your independence, because if your clinician has asked any of the 5 questions I'm about to show you, it may be time to get a second opinion or switch care. These questions aren't always innocent. Sometimes they steer you away from information, limit your options, or quietly chip away at your autonomy. I'm Dr. Alex Monroe, a physician who works with older adults every day. I'll translate the subtext behind each question, show you how to respond in the moment, and give you a 1-page script you can use at your next visit. Stay to the end. Number 5 is the one I see weaponized most often. If you've ever walked out of an appointment feeling dismissed like this video, subscribe, and tell me in the comments what was said and how it made you feel. 1. Do you really want all the details right now? On the surface, this sounds caring, protective even. Underneath, it can be a prelude to withholding. When a clinician floats this line after a scan, a biopsy, or labs, they may be testing whether you'll accept a summary instead of a full explanation. The risk is obvious. You can't make informed choices about treatment, follow-up, or second opinions without the actual numbers and the plain language meaning. Here's how to answer without escalating tension. Yes, please walk me through the results line by line in plain English, then release the full report to my portal today. Follow with 2 precise questions that force clarity. What is the diagnosis or most likely diagnosis in writing? And what are my options, including the option to monitor? Ask for absolute numbers. What's my personal risk if I do A, B, or C? If the clinician seems rushed, say, I'm happy to schedule a follow-up dedicated to results, but I need the report now. The moment you accept a vague reassurance, it's probably fine. You lose time you might never get back. Information is not a luxury, it's the beginning of consent. 2. At your age, is it really worth going through all of that? This one wears a cardigan of concern and hides a blade of bias. It substitutes your birth year for your biology. The translation is, I've already decided this isn't worth my time, your time, or the system's resources. That's not medicine, that's age-based gatekeeping. Your counter is calm and data-driven. Please risk stratify me, not my age. Based on my heart, lungs, kidney function, and activity level. What's my surgical or treatment risk? What outcomes do patients like me, same health status, not same birthday, see at 3, 6, and 12 months? Then drop the comparison that exposes bias. How would you advise a healthy 50-year-old with this exact presentation? Watch what happens. Either you get a thoughtful answer with numbers, or you learn everything you need to know about this relationship. If the procedure is elective and your quality of life is the issue, insist the clinician document function. How far you walk, what pain prevents, what you want to do again. Your goals, not their assumptions, set the target. If they still won't separate age from risk, you don't argue. You get a second opinion from a clinician who treats older adults as candidates, not foregone conclusions. 3. Have you considered just letting things run their course? There are appropriate times for comfort-focused care, but this question should only appear after a transparent review of diagnosis, staging, realistic benefits and harms of treatment, and your priorities. When it arrives early, vague, or with a sigh of wisdom, it can be a soft push toward doing nothing without admitting that's what's happening. Your response restores the sequence. List every evidence-based option for my condition with potential benefits, side effects, and what the next year looks like on each path. Then we can discuss whether comfort-focused care fits my goals. Follow with, what outcome are we trying to avoid? What outcome are we trying to achieve? If they persist without specifics, ask, What is my predicted prognosis without treatment? What is it with treatment? Numbers concentrate minds. If the clinician's recommendation changes dramatically when you pose, what would you suggest if I were 20 years younger with the same findings? You've exposed bias, not medicine. You are absolutely allowed to decline treatment, but it must be an informed no based on your values, not a no you were nudged into by someone else's discomfort. 4. Who's actually making decisions for you? Sometimes this is a routine intake question. Too often it's a quiet downgrading of your voice when a relative is in the room. The danger isn't the question, it's what follows. Eye contact shifts to your daughter. Answers are directed to your son-in-law. Your concerns get summarized by someone who isn't you. In the chart, subtle phrases appear. Family reports. Needs assistance with decisions, without any formal cognitive screen or conversation with you. That paper trail can haunt you. Insurance authorizations, hospital handoffs, even future licensing questions can be influenced by that language. Interrupt the drift immediately. I make my medical decisions. My daughter is here to take notes. If you have concerns about my memory or judgment, say so and use an objective test. You can add, please note in my chart, patient is the decision maker, family present at patient's invitation. If a clinician truly suspects cognitive change, they should look you in the eye, name the concern, and offer a screening or referral, not triangulate through your family. Your mind is not a side conversation. 5. Are you still driving, living alone, managing your own finances? In the right context, these are safety questions. In the wrong context, dermatology visit, routine blood pressure check, they're covert screens for decline without transparency. Answering yes can be twisted into may not be aware of limitations. Answering no can be stamped as loss of independence, monitor for further decline. Either way, a seed gets planted in your record. You don't need to be defensive. You need to require relevance. Try, I'll answer any safety question that relates to today's visit. Tell me why you're asking and how you'll use the information. If a clinician has a specific worry, syncopal episodes, vision changes, neuropathy, they should state it and propose objective assessment, a vision test, orthostatic blood pressures, a driving evaluation through occupational therapy, a referral to a falls clinic. What they shouldn't do is drop a vague note that later justifies restrictions without testing. If you decide to stop night driving by choice, insist the chart say exactly that. Patient elects to avoid night driving, no reported crashes, no cognitive concerns on screen. Precision protects independence. Let's turn these ideas into action you can use immediately. First, bring a written agenda with 3 lines. What is my diagnosis? What are my options? What are the next steps? And why? Hand it to the clinician at the start. Agendas focus busy visits and make it harder for anyone to wave you past the conversation you came to have. Second, control the record. Ask for every lab, imaging report, and specialist note to be released to your patient portal the same day. Say, please don't summarize, I'd like the full report. If something is not released, ask why and when. Information is your leverage for second opinions and your memory when stress blurs details. Third, script your response to each red flag question so your brain isn't stuck searching for words in the moment. For do you want all the details, say, yes, start at the top and please avoid jargon. For is it worth it at your age? Say, risk stratify me, not my birthday. Show me my numbers. For let it run its course? Say, options, benefits, risks, and my goals first. Then we decide. For who's making decisions when say, why am? If you have a concern, test it. Don't assume it. For are you still driving, living alone? Say, explain the clinical link to today's visit and any objective test you propose. Fourth, bring an advocate, but keep your voice primary. Your note-taker sits beside you, not between you and the clinician. If answers slide to them, you gently pivot. Please address me. She's here to help me remember details. Fifth, document your visit in your own words while it's fresh. A simple notebook entry, date, main points, promised next steps, reduces telephone game errors between visits and gives you a record if plans drift. Sixth, know when to escalate and when to exit. If a clinician refuses to explain results, won't provide reports, or repeatedly filters care through your age instead of your physiology, you can. Ask to speak with the clinic's patient experience lead, request a different clinician in the same group, or transfer your care. You don't need to argue. You need to align yourself with a team that respects your voice. A few quiet traps to avoid. Saying, "I'm fine with whatever you think," when you're not. It reads as consent. Instead say, "I need to understand the options before I agree." Accepting normal for your age. Normal is not the question. Desired is. Is this acceptable for my goals? Resets the frame. Letting time pressure end a visit before the plan is clear. It's okay to say, "I hear you're running behind. Please schedule me a follow-up this week to finish this conversation," leaving without your why. Every test, medication, or referral should answer a question that matters to you. Ask, what are we trying to rule in, rule out, or change? Before we wrap, here's a 60-second pre-visit checklist to print and keep by your calendar. Agenda ready. Diagnosis, options, next steps. Portal access, confirmed and working. Med list, updated, including doses, over-the-counter items, and supplements. Advocate, invited to take notes. Your voice stays primary. Question starred, if I do nothing for 3 months, what risk do I take? What would you recommend for a younger patient with my same health profile? What outcome are we measuring to call this a success? And a 30-second post-visit checklist. Did I receive the actual reports? If not, request release. Do I know what happens next and when? Put dates on your calendar. Do I understand what would prompt me to call sooner? Write the warning signs in your notebook. If any part of today's list sounded uncomfortably familiar, you are not overreacting. You're noticing patterns that matter. The good news is that you don't need to be confrontational to protect your care. You need a few sentences, a steady tone, and the decision to insist on transparency. Medicine works best as a partnership. Your clinician brings knowledge. You bring your history, your priorities, and your right to clear information. If this helped, tell me in the comments which question you've heard and how you responded. If you want a printable clinic script card with the exact phrases from this video, type script card, and I'll add it in a future description. And if you've ever left a visit feeling smaller than when you walked in, remember, the problem wasn't your age, it was the room. Find the right room. Stay informed, stay steady, and keep your voice at the center of your care.